honor of presenting to this prestigious group my opinion. Why no treatment is needed for EHIT. Here are my disclosures. I have no conflicts of interest with this talk. Ladies and gentlemen, let me give you some background information which stirred up a hornet's nest early on. Early adopters noticed that there was a unique complication with thermal ablation, thrombus extension into the deep system. In a registry study we reported in 2002, 286 limbs with a 1% incidence of thrombus extension. In 2004, Neil Hingorani and Enrico Asher at the American Venous Forum cautioned all of us by reporting their early experience. 73 limbs with a 16% DVT rate. In 2006, I presented the AVF the classification and definition of EHIT. After analyzing many cases for 3 different institutions, it was certain that there were different patterns of extension. The American Venous Forum Guidelines Committee organized an EHIT writing group to analyze available literature regarding EHIT, to gauge the quality of clinical evidence, and to provide guidance on EHIT's diagnosis and treatment. These guidelines were approved by both the AVF and the SVS and published in the Journal of Vascular Surgery, Venous and Lymphatic Disorders, and the Journal of Phlebology in January of 2021. The AVF updated the EHIT classification by adding to EHIT 1. We added to the KAbnik classification 1A, peripheral to superficial epigastric vein, and 1B, central to superficial epigastric vein, up to and including the deep vein junction. Now let's talk about EHIT guidelines. There are 15 guidelines with regards to EHIT. With a time limitation for this talk, I've selected some but not all. Let's start off with Guideline 3.2. Guideline 3.2, treatment for EHIT 1. Just as you would think, we suggest no treatment or surveillance, grade 2C. Guideline 3.3, treatment for EHIT 2. We suggest no further treatment of EHIT 2, but with weekly surveillance until resolution thrombus retraction, grade 2C. As an alternative for EHIT 2, and if you must, consideration may be given for antiplatelet therapy or anticoagulation for EHIT 2, weekly surveillance with cessation of treatment following thrombus retraction to the saphofemoral junction, grade 2C. Guideline 3.4, treatment for EHIT 3. We suggest treatment with anticoagulation for EHIT 3, weekly surveillance and cessation of treatment following thrombus retraction to the saphofemoral junction, grade 1B. And finally, ladies and gentlemen, Guideline 3.5, treatment for EHIT 4. We suggest that treatment should be individualized, considering the patient risk factors, bleeding risk, and reference may be made to the CHEST guidelines for the treatment of a provoked VTE, grade 1A. Now let's try and answer the question, should we worry? In 2014, Dr. Jones and I published in the Journal of Invasive Cardiology is perioperative duplex following endothermal ablation of the saphenous vein. Is it worthless? And we concluded, yes. Why look for EHIT? If what we know now, the incidence of EHIT in all comers, EHIT 1 through 4, is about 3 to 4%. EHIT 2 is 1 to 2%. And the incidence of PE by EHIT at most is 0.03%. Are EHITs even dangerous? Our own short series, 10 patients with EHIT 2, all monitored with serial duplex, 9 out of 10 placed on therapeutic low molecular weight heparin, 10 out of 10 had resolution of EHIT within 14 to 21 days. After resolution of EHIT, chest CT showed PE in 2 out of 10 patients. All patients were asymptomatic. None suffered significant sequelae. What does this mean? So let's stop worrying about EHIT 1, 2, or 3. Why look at vein closures immediately post-operative? We know the immediate thermal closure rate is high, so why look? Because it makes us feel good? Let's look at some facts. The number of thermal ablations performed annually is greater than 600,000 in the United States and approximately 60,000 in the United Kingdom. The incidence of EHIT2 is approximately 2%, yielding 12,000 per year in the United States or 1,200 per year in the United Kingdom. The incidence of clinically significant PE from laser radiofrequency is 0.01%, or 60 patients in the US and 12 patients in the United Kingdom. The number of duplexes performed to find one EHIT is 100. The number of duplexes performed to potentially prevent one PE is 10,000. At most, 60 patients a year will have a clinically significant PE. Now let's look at the cost of duplex. The cost of duplex in the United States is approximately $350 to $500. The number of duplexes needed to potentially prevent one PE is approximately 10,000. The cost of preventing one PE is somewhere between $3.5 to $5 million. Ladies and gentlemen, in conclusion, duplex ultrasound in the postoperative period is wasteful and not efficacious for the prevention of complications or treatment failure. Thank you for the opportunity to present this controversial subject, and hopefully I'll be able to return to Egypt soon.
Thank you, sir.